Sorry?
Hello. Good evening, all. Just looks like the usual traffic and stuff of the Longwood area. People are still coming in. We'll just wait for a couple more minutes and we'll get started. In the meantime, if anybody can tell good jokes, you're welcome to come on down here. Or sing. Or any other thing to keep people engaged, entertained. Because I don't know how to do that.
You want to put the screen share on? And then where are your slides? Do you want to do it as a screen share? Well, how it was before?
Pardon?
Oh, you.
Yeah, so this will go to my slides.
Yeah, okay,
And so after it
Good evening, everyone. Welcome to the 42nd Annual Garland Memorial Lecture. And sorry for the little bit of a late start. I don't know why, but people should be coming in. There are many more registered. They should be coming in. But we'll get started. I'm Jay Sankaran. I'm the president of the Boston Medical Library. And thank you all for coming. I'd like to recognize, I think she's not here yet. I think I want to skip that. Okay. I'd like to tell you a little bit about the Boston Medical Library, which is the one that's sponsoring and arranging this lecture. And we just got this new banner, so make sure you look at it. So I feel satisfied that the new banner has been viewed by people. But let me tell you a little bit about the Boston Medical Library. 214 years ago, to be exact, in 1803, John Collins Warren, James Jackson, and a few others got together and started in 1803 the Medical Improvement Society, which used to meet at each other's house to discuss medical papers. And then they collected in the home of Dr. John Fleet some of their books and incorporated in 1805 as the first Boston Medical Library, the purpose being to serve the library needs of the practicing physicians. It was indeed far-sighted that far back to create a library for practicing physicians, and sometimes it appears to me, even today, it is kind of far-sighted because it's not available readily for practicing physicians. It went into hibernation in 1826 with the sizable collection being deposited in the Boston Athenaeum. Pretty soon, the need for a library in the Boston area was acutely felt. Young James Chadwick was the person who took that lead. The current Boston Medical Library opened its doors at 5 Hamilton Place on October 18th, 1875. Today is 17th, so one day, tomorrow will be an anniversary. With Dr. Oliver Wendell Holmes as president and Dr. Chadwick as the librarian. And in 25 short years, the library built its own building at 8 the Fenway, which was a famous address for quite a while, and it housed 2 prestigious journals that you see here, the brass plate at the entrance of the building, the New England Journal of Medicine and the Journal of Bone and Joint Surgery. Soon after that, the Harvard Medical School moved from Copley Square to the Longwood area in 1906, and pretty soon found it kind of frustrating to go to the Boston Medical Library on the Fenway to access many of the material that was only available at the BML. There was an interest, even at that time in 1935, to combine the 2 libraries, and Dean Sidney Burwell at that time started some early efforts, but didn't succeed. The 1958 gift from the Countway Charitable Foundation enabled the creation by 1965 of the Countway Library for housing the Harvard Medical Library and the Boston Medical Library collections. In addition to its stacks of current literature and the invaluable BML historical collections of rare books, paintings, prints, and artifacts, all moved and combined into Countway to create one of the largest and most valued collections under one roof. Dean Packer Berry said at the inauguration, and I quote, "It's inappropriate for a community to support 2 medical libraries, one for the medical school and the other for medical practitioners. It's important that the practitioner as well as the academician have ready access to the collections and services of a university medical library, lest he become isolated from the moving front of discovery." If he said that today, he would have probably said she, but you'll have to pardon him for the times. And today, Chadwick would be proud to see the collaborative efforts of the Boston Medical Library, the Harvard Medical School, the Massachusetts Medical Society, and others to continue to expand the horizon from the ancient and current to a future including IT, bioinformatics, and to being an active resource, reaching out to help the learning of the profession through its entire life cycle, from the medical student, teacher, and researcher, to the physician caring for one patient at a time in her office, struggling to find the time to learn the best way to do what she does best. Through all this, the Boston Medical Library never swerved from the original mission to improve medical care, and in the process, celebrate the history of the profession's continual struggle to do so, captured in her motto. Before that, this is an artist rendering of the first public demonstration of ether anesthesia at MGH in 1846. And this portrait hangs in the rotunda of the library. And that motto of the Boston Medical Library, captured in her seal, serveth et docet, to mean preserve, to preserve and to teach. Now, changing gears a bit, it's indeed an honor for the BML to host the Garland Memorial Lecture in honor of its 13th president from 1967 to 1970. Dr. Joseph Garland, a legend in his own time, a beloved baby doctor, educator, clinical investigator, scholar, poet, and author, and the editor of the New England Journal for 20 years, from 1948 to 68, generally credited for making the journal what it is today. He was no less a devoted husband and a family man. Of Dr. Garland's wisdom and discipline in writing, it is said that he would write his editorial standing up and end as he began to tire, in the belief that by then, the reader, like himself, would have had enough. I'd like to thank Dr. Dale McGee. Dale? Yeah, come on down. Who chairs the Garland Committee, and the members of the Garland Committee listed here, for their hard work in arranging today's outstanding presentation on this very important and timely topic by this most distinguished speaker, whom I shall ask Dale to please introduce. Dale?
Thanks, Jay. Hello, everyone. One little piece of business before I get started with that. Dig them out, make sure they're on vibrate, so we can enjoy this lecture. I also want to echo what Jay said about our committee for selecting the speaker for this today's lecture. The other members of the selection committee were wonderful. They were thoughtful, hardworking, and they made the selection process a real pleasure. But our task was made easier by the fact that we also got our first choice this year. The topic today is at the center of healthcare delivery crisis, not only here but around the world. When systems try to control costs, it is critical that they understand value. We're very fortunate to have Dr. Peter Neumann presenting the 42nd Garland Lecture. We're fortunate to have Dr. Peter Neumann presenting the 42nd Garland Lecture. Dr. Neumann obtained his bachelor's and master's degrees from the University of Pennsylvania in economics, and a doctorate from the Harvard School of Public Health and Decision Sciences. He served on the faculties of Harvard and Tufts, and is currently a professor at Tufts Medical School in their Institute for Clinical Research and Health Policy Studies. His experience in the realm of measuring value in healthcare is extensive. He has authored or co-authored nearly 200 peer-reviewed articles, published 2 books, served on committees for the federal government, Project HOPE, as well as various committees at the state and local level, and has served on editorial boards of 5 journals, as well as consulting in the commercial sector. He's also the founder and director of a cost effectiveness registry, which is a website that you can go to free of charge. It's a comprehensive database of cost effectiveness analysis in healthcare. It's a really interesting resource. If you're interested in this topic, I'd suggest you put it on your favorites. So we've got a real expert today talking about an extremely important topic, and we'd like to welcome Dr. Neumann, and we look forward to what you've got to tell us. Thank you.
Thank you. Thank you very much, Dale. It's really a great honor and a pleasure to be here. I know of the great work of Dr. Garland over the years, And what an honor to be asked to speak to you as the Garland Lecture speaker. I'm also a great fan of libraries. I spent many, many years, well, not many years, but some years as a doctoral student across the way here, many hours in the QALY Library. In those days, we used to copy the articles in the basement. I don't know if we do that anymore, but very fond memories of that. I will confess to being a little bit nervous today. I give a lot of talks. I've been the dinner speaker, the after dinner speaker. I don't know that I've ever been the right before dinner speaker, so it makes me a little nervous. I want to talk about value in healthcare, measuring value, and I want to do so through the lens of cost effectiveness analysis. And that's I will argue, a useful prism by which to, or through which to look at larger themes in the healthcare system, economic, social, political. There are a lot of people measuring healthcare, maybe value in healthcare, maybe some in this room. Cost effectiveness gives us metrics, measurement, empirical measurement tools, and it's a useful way to think about this. So let's get right into it. I'll talk about progress, I'll talk about challenges, and I'll think some thoughts about looking ahead, and then look forward to your questions. So let's start with progress, and I want to start with the importance of measurement, and I thought I would start with our friend Bill Gates. Bill Gates, of course, the founder of Microsoft, the richest man in the world. Once in a while, some years he falls to number 2 or 3, but happily for him, the Forbes 400 came out today. He's number 1 again, so not to worry. But having amassed his fortune, he creates the world's largest foundation focused largely on global health. And Bill Gates writes an annual letter that I like to read, and I would encourage all of you to read if you don't. It's very thoughtful. A few years ago, I was struck in his annual letter of 2013, which he modestly titled, "My Plan to Fix the World's Biggest Problems." If you're the world's richest man, you think big. Interestingly, the letter wasn't really about the world's problems per se. It was about measurement as the way to solve the world's biggest problems. And he wrote, "I've been struck by how important measurement is to improving the human condition." It's about measurement. And he talks about this book, the most powerful idea in the world. Maybe some of you have seen or read it. It's a history of the steam engine and a history of the Industrial Revolution by William Rosen. Rosen writes in the book a lot about measurement as the key to the steam engine and really the key to the Industrial Revolution. Because there were lots of ideas for steam engines and lots of people with incremental innovations, proposals for others. But how do you know if one steam engine is better than the other? We needed measurement tools, Rosen argues, and Gates recounts this in his letter. We need measurement tools to measure the efficiency of engines. We need measurement tools to measure small distances. We need things like the micrometer. If you Google early micrometer, you see one of those pop up. And Rosen writes, "Without feedback from precise measurement, innovation is doomed to be rare and erratic. With it, that is with measurement, innovation becomes commonplace." And Gates goes on to say we can learn a lot about improving the world from improvements in measurement. And then he goes on to talk about healthcare. And he talks about measurement in healthcare from, in a sense, his own position as the head of the foundation. How can he spend his foundation's money to improve health, and how will he know? That's a measurement question, really. How can he measure the impact of investments in different strategies? So that brings us to measurement in healthcare. Every clinical encounter, virtually, is an encounter with measurement, right? Somebody comes into the clinic, into the office. We measure height, weight, BMI, blood pressure, HbA1c, lab values, on and on. Seldom do we measure the value of what we're doing explicitly in healthcare. And that's what Gates talks about. And that brings us to this question. I often ask my class and audiences, maybe I'll even ask here, how should society spend its limited resources to improve population health? That's the question. Anyone want to throw something out? Any ideas, broad areas? How should we think about this question? Well, oh, somebody said?
Vaccines.
Vaccines, yeah. Good, yeah.
Clean water.
Clean water, vaccines. Anybody else?
Education.
Education, great. Yeah, we could think of others. If this were my class, I'd be more Socratic and we'd spend a lot of time. But yeah, these are great. I mean, these are the things we think about. Often I get these responses. Prevention. mental health, high burden diseases, social determinants. We heard some of these, education, vaccines, they're in here. These are all good answers, but in a way they're intuitively appealing, right? This is where you'd want to look. Prevention, sounds right, highest burden diseases, and some of these others, education, vaccines, clean water. But at best they're incomplete, these answers at least, because they're giving us areas broadly, but they're not telling us specifically what we would do in these areas. What kind of prevention? What kind of mental health? And that brings us to the Bill Gates and the sort of larger societal question about value. How do we measure such things? Well, what metric would we use? We could measure prevention, at least certain kinds, screening for cancers, cancer cases detected. Maybe we could measure depression screening or treatment with a depression scale. The problem from the kind of global Bill Gates-like question or societal question is, how do you compare money spent to prevent cancer with money spent on mental health? We need a standard metric. And so economists and others have been thinking hard about standard metrics over the years. Lives saved. What do we know about the impact of interventions on lives saved if we vaccinate or we have clean water interventions? It's getting ourselves there because we can compare lives saved across interventions, but of course it's incomplete. Different people have different life expectancies, so we don't want to just have lives saved. But not to mention the fact that there's never truly a cure, we're just delaying death. So we'd like to know something more about the magnitude of the effects. And we could go to life years saved, right? Life years saved tells us something about how many years of life we're getting. The problem with life years saved is, intuitively, a lot of what we do in health and medicine doesn't reduce mortality or increase life expectancy, it improves quality of life. Most of what we do to treat symptoms, for example, reductions in pain, for example. We need a standard metric, ideally, that's capturing quality of life and mortality reductions, life expectancy. And so economists have hit on this concept of the quality adjusted life year and the QALY. So some people, I think, probably know QALYS and have thought about it, but QALYS gives you a single number to capture quality of life, or you might argue morbidity and mortality in a single number. So what's a QALY? So here's an example. Imagine we have a treatment for Parkinson's disease, and on the x-axis we have years, y-axis we have a health utility. It tells us something about the quality of life between 0 and 1. 1 is perfect health, 0 is dead. The numbers tell you something about the level of impairment. Person with Parkinson's has a 0.7, let's just say arbitrarily. And then let's say they're living with a 0.7, then they get a diagnosis of Parkinson's, then they decline, okay? That's QALYs without treatment. We could trace the trajectory and add up the QALYs. And then imagine we have a treatment that improves this person and extends their life, right? They get more life and they get better quality of life. The area here would give us the incremental QALYs. And then we could do this for costs, in theory, right? Trace out all the costs with treatment, without treatment, trace out all the QALYs, and we could get a cost-effectiveness ratio. So economists have been, and other researchers, have been doing a lot of work over the years with cost-effectiveness ratios. And the idea is we have a delta cost, delta QALYs. Delta cost is telling us something about treatment costs, net savings. Delta QALYs is telling us something about the QALYs with the treatment minus the QALYs without the treatment. How many people here have seen QALYs before? Some. Okay. So we're going to talk about cost per QALY ratios. And the idea is we could trace any intervention in terms of its impact on health, which we're going to measure in QALYs. A new intervention, whether a vaccine or a treatment, a drug, a diagnostic, or procedure, is going to increase or decrease QALYs and increase or decrease costs. And we're going to put people in different quadrants, or treatments, interventions in different quadrants, depending on whether they increase QALYs, decrease QALYs, increase costs, decrease costs. So here, more effective, less costly. Maybe this is the clean water intervention. It actually saves money if you add up all the costs, and it increases health. That would be in that quadrant. We might have, this would be an unambiguously poor choice. It's less effective and more costly to be in that quadrant. Often we're in quadrants here, especially up here. We're increasing QALYs and we're increasing costs. A lot of new technologies, new interventions end up here. And what the cost per QALY is telling us is how much we're getting for how much we're spending. It's a measure of value. And it's a powerful concept because it's giving us one number, cost per QALY. It's telling us something about value. And we can use it to compare anything in theory. Vaccine, water, education, drugs, anything. So imagine we have drug A. Gives us a lot of QALYs for relatively little cost. Everybody see it? You're getting a lot of QALYs, relatively little cost, compared to, say, drug B. Drug B, a little bit of QALYs, a lot of costs. So at least if we're just looking at cost effectiveness and value, drug A is more cost effective than drug B. Everybody got it? And in theory, we could do this for any intervention, and we can address the Bill Gates question. We can address our societal question with numbers, with precision and metrics. And we might be down here. Maybe that's our vaccine. It actually saves money. Even if we consider the cost of the vaccine, the idea is it could save money because we're going to avoid all those costs that we would have had otherwise. Okay? Everybody's with me so far? So my colleagues and I, and Dale mentioned this, have been collecting cost per QALY ratios in a database called this Cost Effectiveness Analysis Registry. That is our website. Feel free to go. We make data publicly available. We've been collecting thousands and thousands cost per QALY ratios to try to help us and decision makers broadly, not just Bill Gates, but health insurers, clinical guideline writers, Medicare program, others. What's the value of interventions? So we have 6,749 studies in the database. These are all English language, original cost per QALY studies. Many studies have more than one ratio, so we have something like 16,000 ratios. The last year we had 752. We have 2 people reading each study, collecting a lot of information, standardizing it, putting it into a database. Let me give you some examples. So to orient you, I'm going to show you some interventions that are cost-saving, and then we're going to go progressively up the cost-effectiveness scale. Remember, higher numbers are worse value, right? More expensive ways to produce units of health. So let's just look, and this is just kind of a random sample. We have literally thousands and thousands of these. Hep A vaccination for children in high prevalence areas. Study that we thought was a good study showed probably saves money for society. Subsidizing fruits and vegetables with SNAP program, that's the Supplemental Nutrition Assistance Program, saves money. Colorectal cancer screening, compared to no screening for 50 to 75-year-olds. Now, each of these is its own story, which can get complicated. I'm giving you very top-line results. So if anybody has a specific question, we can go in detail. Colorectal cancer screening probably doesn't save money, but it probably has a relatively low cost per QALY ratio, meaning probably not bad investment if you're just looking at value, whatever it is, 20 to 50,000 in that population. And then we can go way up the scale. These are the new TKIs, the tyrosine kinase inhibitors for non-small cell lung cancers. Probably in the area of 150, 200,000 per QALY. Not to say that we shouldn't reimburse for them, but to say that that's telling us something about value, and it's relatively poor value compared to these other things. And then some of the new treatments, these are the PCSK9 inhibitors that probably lots of you know about for cholesterol reduction. Depending on assumptions and populations, many hundreds of thousands of dollars, 400,000 or so per QALY. And again, these are nuanced stories. Each of these has a target population, a comparator, assumptions that go in. But these are all simulations of total cost and QALYs that would result by treating a cohort population with these interventions. We can go on and on. Here's bevacizumab for metastatic colon cancer. You get the idea. We can address the value question with data like this, and it's a powerful way to think about value, especially given the challenges our country has. We know we're spending more than we have. We know there's a lot of inefficiencies in the system. We know compared to other countries we're getting poor value. This could help us better target resources is the idea. And so my colleagues and I have been writing lots of papers. We've met many dozen papers at this point. Here's one. 2008, we wrote this paper, Does Preventive Care Save Money? Health Economics and the Presidential Candidates. So if you could remember back to the halcyon days of 2008, with that presidential election, with Hillary Clinton, Barack Obama, and John McCain, there were a lot of claims about prevention. And many of the candidates were saying, I'm going to do more prevention because it saves money. Now, economists have looked at this for a long time, and we looked at it again. And we said, well, let's look at the data. And some prevention saves money. Tobacco use, screening, and counseling. I showed you Hep A for kids and vaccination and some others, SNAP program. But not all prevention saves money. Here's daily PrEP, that's pre-exposure prophylaxis for high-risk men having sex with men to prevent HIV. Maybe a very good thing to do, but probably doesn't save money, is the point. We pointed this out in this New England Journal paper, 20,000 per QALY. And it depends a lot on how you target these interventions. So here's daily PrEP, same intervention, but now we're not targeting. This is for all men. Imagine we give this to all people. All men having sex with men to prevent HIV. We still might want to do that policy, but it's a lot less cost effective. That's the point, right? We can compare these, and we can give this information out to people making decisions and say, hey, you know, we could do more of the things on this side and less. But these sweeping statements that prevention saves money are really not that helpful. We need to be more precise. That's the point. Biannual mammography, biennial. For 50 to 74-year-olds. Big controversy in mammography, even apart from the value story. The value, depending on assumptions and such, about 150,000 per QALY. If you go to annual mammography for 40 to 70-year-olds, which is the guideline in many cases, less cost effective. Anybody know why it's less cost effective? Anybody has an intuition? I can't help my professorial role here.
Excess testing.
Sorry, say it again?
Excess testing.
Excess testing. You're testing more, right? And let's just push that a little more. Why would that be less cost effective?
More false alarms.
Yeah, more false alarms, more false positives. Another reason, though, nobody said yet. That's in addition to that one, which is a good reason. Yeah.
The associated cost of treatment for unnecessary treatment.
Yeah, the associated cost of all the unnecessary treatment that will result from all of the false positives. Yep. Yeah, the yield's lower. And the reason the yield is lower is that the prevalence is higher. So we're screening higher prevalence populations. We're going to get some more QALYs, actually. But if you look at the cost per QALY, we're going to spend a lot more money per QALY. That's the point. And you could imagine, you know, every 6-month testing, every week testing. We're not going to do those policies. Clinically, we probably wouldn't want to do them anyway. But it would be very, very expensive as a strategy to improve health. That's the point, right? So we could do that. And the other point of this New England Journal article is treatment can be also cost effective. Here's sofosbuvir, that's Sovaldi. Big controversy about Sovaldi, right? Sovaldi is very expensive, big budget increase. But the cost effectiveness, the cost per QALY seems pretty good if you judge, and most people conventionally we say 50, 100,000 per QALY, maybe 50 to 150. That's probably a range that we'd say is cost effective. And again, not to say we wouldn't reimburse for things above or always do it below, but that gives us some guideline. And some treatment is not. Here's Provenge, if you remember Provenge for prostate cancer a few years ago. Many, many hundreds of thousands. The point of the article is we can't make sweeping statements. Sometimes treatment is cost effective, sometimes prevention is not. We need to do the analysis. Okay, it's part one of the talk. There's a lot of progress. We can do it. It can help us. Now I want to get to challenges. Okay, if it's so great, why do we have this? This is our friend Joe Selby. He's head of the PCORI, which is the Patient-Centered Outcomes Research Institute, an agency created by the Affordable Care Act. And he's a very good researcher, very smart guy. But he said, they're never doing a cost-effectiveness analysis. Now, how could this be? I just told you it's so great and so powerful. Well, the reason is the Affordable Care Act, right? Obamacare, the ACA, 2010, 2,000 pages of legislation, but it has a clause: the PCORI shall not develop or employ a dollars per quality adjusted life year as a threshold to establish what type of healthcare is cost-effective or recommended. The ACA tells the PCORI they can't do cost-effective. There's a disconnect here, right? Now, for somebody who does cost-effectiveness for a living, this is like getting a cease and desist order from the government. This is like the government telling me to stop what I'm doing. Why? Well, here's another piece my colleague Milt Weinstein and I did in the journal a few years ago. We've legislated against it. And there's other pockets, more than pockets. There's other resistance. CMS, Medicare, and Medicaid, CMS, the Centers for Medicare and Medicaid, spends $1 trillion a year at this point, $1 trillion, okay? They are not permitted to use cost-effectiveness analysis to guide their decisions. It's ludicrous, but that's the law without a change in statute. A lot of the headlines recently were about Tom Price, right? Remember, Tom Price was the HHS secretary. He got in a lot of trouble for taking flights and not paying for them. He probably spent, whatever, $800,000 on flights. It's about 20 seconds of Medicare spending. So, and all the headlines went to Tom Price, not to this. This is the real problem. But here we are. The question is why? Why is this happening? And this is, again, a good opportunity to ask you, but let me just, in the interest of time, and I want to get to your questions, let me just pose some possibilities that probably are in your head. One is, I haven't said anything about the methods yet. Maybe the methods are not very good, and we really can't compare these things. What about the motives of people who are doing these? Maybe they're not really credible. Maybe. I'll get to each of them. There's a lot of ethical issues here. Probably you've been thinking about them, and you know them. Well, that's a possibility. And then there's political reasons, which perhaps are related to the ethical ones. But there may be others. Let's go through them and talk about each one. Let's start with methods. What are we measuring? QALYs are measuring quality of life of patients. Isn't that hard to capture? Yes, it's very hard to capture. Is it really capturing what people care about? Maybe, maybe not, but there's certainly a lot of questions about that and a lot of research about it too. And much of the research is saying, well, this challenge is here, but we could do this actually. And being in a vegetative state is really bad, and being in a state with a mild headache is not so bad. And we can rank things reasonably well. And it's better than not ranking. But there are certainly measuring questions on the QALYs. And on the cost side, what are we measuring and over what time horizon? A lot of the payers will say, we don't want these cost per QALY ratios. We only care about our budgets for the next year. That's what we worry a lot about. Or at least we worry a lot more about that than we do about the cost per QALY. But there are a lot of issues about the time horizon, the components of health, on and on. And then there's this issue of perspective. Whose perspective are we measuring? And the idea is a lot of these studies are done from a health perspective, a narrow perspective, considering the health costs, medical costs. But there may be a lot of other components that we care about. For example, caregivers. And we might want to do a broad societal perspective. After all, that's the question I posed to you, right? What do we know about how we could spend society's resources? What about caregivers? You treat the child with asthma, you are having big impacts on caregivers. For that matter, you treat the Alzheimer's disease, if we really could, tremendous impacts on caregivers. True for almost every disease. Most studies are not measuring that, and probably undervaluing the interventions, by the way. What about productivity? Again, if you treat the depression, those people might well go back to work. Isn't that a value to society? Generally, we're not capturing productivity. What about others? Because sometimes called these spillover effects. You treat the substance abuse or the patient with schizophrenia, you might reduce crime. Isn't that a benefit? We can measure those things. We can measure all of these things, but typically we don't. So I was recently the co-chair of the second panel on cost effectiveness, national guidelines. And we argue that we should be able to improve our methods. We have been improving our methods. We also argue analysts should take a broad societal perspective and a narrow healthcare perspective, because we really would like to know both things generally. Narrow because that's what payers seem to care about. Broad because we should be capturing those broad components. Okay, so we can come back, but there is some evidence that the methods are improving, and that, you know, I think that arguing that the methods are getting in the way is overstating it. After all, those who would like to measure value for their own populations, like the Medicare program, they can do their own analyses and make sure the methods are good. Okay, let's keep going. Motives. So we have documented, and others have too, there's a kind of a bias in a lot of the analyses that are out there. And there are two kinds of bias we talk about in this paper. This is from BMJ, about 10 years ago. One is a publication bias. Journals tend to publish more positive findings. Not the New England Journal, they would never do that, but other journals. Other journals out there, you know, JAMA, other journals. No, but this is documented in clinical literature too. But the idea is that people are, you know, only putting these positive studies out there, and we don't have a lot of, and there's some evidence of that. We documented. Although, you know, there are also at least some number of studies that are not cost effective. The other type of bias is a pharmaceutical industry bias. You know, drug industry companies tend to put favorable studies out there, even more than others. But again, while that's true, it shouldn't be the obstacle, because if you are the decision maker, you know, only look at if you like and choose, only look at the non-pharmaceutical studies, or do your own studies, that some people have done. Okay, let's talk for a moment about ethical challenges. This is a big deal. We have a whole chapter in our book on ethics. There are lots of ethical challenges. Maybe the top one that people talk about is cost per QALYs don't give priority to the sickest, the disadvantaged, most vulnerable, most disadvantaged. The idea here is, if you ask people, this group here or any surveyed population, we're not naturally QALY maximizers. That is, we tend to want to give priority to those most in need, whether it's cost effective or not, right? I mean, that's a strongly held ethic. And one of the reasons we balk at some of this information, and one of the reasons it's been so hard in the public arena, is precisely this kind of pushback. A related one is that cost per QALYs discriminate against older people and the disabled. The idea is older people don't have as many QALYs to gain, so we're going to disadvantage them. And disabled people, you could construct scenarios where cost per QALY ratios discriminate. Imagine I have two people. One is disabled and has a baseline utility of 0.5, right? That's all they go back to. The other one is perfectly healthy. They're suffering from the same life-threatening illness. I've got a pill. I can give it to one or the other. It's $1,000. The idea is it would be much more cost-effective to give it to the healthy person, because they go right up to the one. The other person goes. You can construct scenario. On the other hand, the counter to that, to both of those, is one, typically people who are sick, impaired, and often older, I showed you the mammography example, do better in cost-effectiveness analyses. Why? The yield is higher. The prevalence is higher. It's usually not cost-effective to treat healthy people. It's cost-effective to treat those who are more impaired. So they often show up as being better. Not to mention, if you have specific cases, you can override this. But the more powerful argument, perhaps, is if you don't do cost per QALYs, whatever you do, whatever your decision rule is, you will have distributive consequences. You will be discriminating in some ways. You can pretend you're not, but we are making decisions. And this is information. The idea is this is information that can help us alongside a lot of other information. And, you know, we can come back to that, but if we want to understand value broadly, the argument is this is a good way to do it, and it's better than not having it. There are other ways the QALY falls down. Small benefits to large numbers of persons versus large benefits to small numbers. The idea here is, imagine there's 1,000 people in the room, you all have a mild headache, and I can treat you all for $1,000. So we get one QALY for $1,000. Let's just imagine, because you all have, imagine the decrement in QALY is, you know, 1 in 1,000. And then I have one person who has a life-threatening illness and it will die without my $1,000 pill I can give to them. Who would you rather give the money to? And we're getting one QALY in each case, right, for the $1,000. Everybody following that? Most people would give it to the person who would otherwise die. But the QALY doesn't discriminate. That's the idea. But again, we can always create scenarios. But the counter is, if we don't do this, we're not bringing information in a standardized form to the decision maker. Okay, politics. What can I say? There's not a lot of appetite in the public arena to talk about limits, rationing, especially today in this public arena that we're having in the country. We wrote this article, I wrote this article in the New England Journal a few years ago. What do we talk about when we talk about healthcare? And I was admiring the American College of Physicians, who said the physicians have a responsibility to practice effective and efficient healthcare and to use healthcare resources responsibly. They go on. Parsimonious care that utilizes the most efficient methods or means to effectively diagnose a condition, treat a patient, respects the need to use resources wisely, and so forth. So this is the American College of Physicians saying physicians need to be judicious stewards of resources. Very interesting. Often you don't see this in the public arena. You see a lot of talk publicly about, well, we'll get at waste and inefficiency, that good quality care is the way to get save money and so forth. Not a lot of talk about limits. Okay, let me end on looking ahead, and then I'll look forward to your questions. And I want to end on a more optimistic note, even as we recognize there will always be challenges here. But I do think there are some reasons to be optimistic. So here's a paper that I did with my colleague, Jillian Sanders, earlier this year in the journal. We call it Cost Effectiveness Analysis 2.0. And we argue there's some, what we call green shoots, some reasons to be more positive about where we're going. Why? Well, one is there's a lot of publications coming out, most of them, many of them from the US. Some of these are from England and other places. So there's no drop-off. Even as we have all these challenges, there's more and more information out there. That's a positive sign. There are also groups like this group, the Institute for Clinical and Economic Review. Anybody here have heard of this institute called ICER? If you haven't, it's an institute worth putting on your radar. And they're based right here in town. They have become a kind of private NICE. UK has this group called NICE, you may know, the National Institute of Care Excellence. Institute of Clinical Economic Review has been putting out cost per quality ratios to help private decision makers, health plans, and now the VA, and maybe in the future other public plans. They're putting out cost per quality ratios. They put out one for diabetes prevention, 20,000 per quality. MS drugs, TKIs, RA drugs. They're putting these out and they're saying, a lot of the stuff we're doing is not cost effective, their headline. And if we want them to be cost effective, we need to reduce the drug price. It seems to be having some traction. You see headlines like this in the Boston Globe. Boston Watchdog takes aim at rising drug prices. Group says top priority is value, not what the market will bear. Drug pricing, we can talk about it in the Q&A. It's complicated. There are a lot of things that go in. But the idea is we can bring to information on the value of drugs now with cost per quality ratios and use that information to help us think about whether we're getting good value for the money. There are other groups that have been using cost per qualities. CDC has a group called ACIP. That's the Advisory Committee on Immunization Practices. They use cost per qualities. There are some other pockets of, call it optimism, I think, as well. Okay, so I thought we'd end back with our friend Bill Gates, because Bill Gates has been talking about not only the world's biggest problems and measurement as a means to address them, but he's been talking about these questions that we've been talking about here. What's a year of life worth? How do we think about it? And in an interview recently, he had a quote, and he called it, well, they call this thing the disability-adjusted life year, the DALY. The DALY is like the QALY. There's some technical differences, but it's the same concept. And you can produce cost per DALY averted ratios. Anybody here have seen DALYs before? Yeah. A dolly is like a QALY. And again, if you're interested, we can talk about the technical differences, but the similarities are a lot more important. So here's Bill Gates trying to answer his question. Where should he invest his vast resources? And how can we think as a country about investing our resources? He talks about global health, and he said, when you're running a poor country healthcare system, you can't treat a year of life is worth more than, say, $200, $300. So they're in a very different system. Or else you'll bankrupt the healthcare system immediately. So I'm pleased to say that the Gates Foundation gave my group a nice grant recently to build a cost per dolly ratio database to look at what do we know about the return on investment in terms of cost per dollies for all kinds of different strategies. So we now have many thousands of ratios in our cost per dolly ratio database. And here are just some selected ones. Routine polio, and this is on a global scale, often with different regions in Africa and Asia involved. Routine polio vaccination. Here's HIV self-testing in Zimbabwe, cost saving. Now we're at a very different scale. Remember, these are low-income countries. We're not talking about $50,000 per QALY. We're talking about $100, $300 per QALY. Rotavirus vaccinees in Gavi-eligible countries. That's the global initiative on vaccines. Drinking water, we talked about before, and this is in global health settings for treatment of cholera. At least that study said doesn't save money, but good investment, $600 per dolly. And then, you can keep doing this. The idea. Here's treatment of MI in Mexico with aspirin, beta blockers, ACE inhibitors, and so forth. You get the idea. Universal hearing screening for all live births. We can address the Bill Gates question. We can address our societal question. And I guess I'll just close by paraphrasing Bill Gates. We can learn a lot about improving the world in the 21st century from better measurement of value and cost effectiveness. So thank you very much, and I look forward to your questions.
Thank you for that wonderful presentation. I think we've solved half the problems of the world. No, not really, but we're getting there. Thank you for that. Any comments, questions? Can you turn the light on, somebody? Yeah.
So this was a great presentation, a lot to think about here, but it seems that one of the controversies is that people are afraid that someone else is going to be making decisions, life and death decisions for them.
Right.
And it seems that this technology that you're talking about could be used by patients to consider not just whether to treat or who to treat, but which alternative to choose.
Right.
Since we often have choices that may work out differently. What are your thoughts on
Yeah,
that?
so good question. The second part is what about patients and their...
Can you just repeat the question?
Yeah, so I'm trying to get... The first part is around somebody else is going to be making these decisions for us, and how do we think about that? The second part is, could patients use this information? So part one, this is very challenging, and the rhetoric you often hear from people who don't like this is, this is going to be bureaucrats getting between doctors and patients, or someone else making these decisions for you, and it's somehow, this is not how we want decisions to be made. Again, the response, I think, is resources are limited, whether we want to recognize it or not. And being explicit about this really allows us to have more health for the population. And if we don't do this, we're making ad hoc, inefficient decisions. And it's going to be hard to do, but I showed you the mammography screening one. I showed you the HIV treatment or prophylaxis one. Every clinical decision, every policy decision has resource implications. We're trying to put numbers on it to give that information to the policymakers, usually making population-wide decisions. I think this is hard for patients, actually. And for those making the population-wide decisions, we can produce more health, and that's all we can do. Now, certainly patients can look at this information and say, I'm not going to get a lot of health for that cancer drug. the study show. And maybe that would be helpful to them to know that. So if that's where you're going with that question, I would agree. There might be ways that the patient might value that information. Now, on the other hand, the patient might say, I don't care what the cost per QALY is. I want that drug because if there's any positive benefit or even any chance of a positive benefit, I want that. And that's a tension that we will always face, right?
Thank you again for your talk. A question related to definitions, because you had defined cost effectiveness as the cost divided by the QALY. I think often in medicine we define value rather, not that with that ratio. We define it as quality divided by cost.
Yeah.
So I think that intersection, I think those are very important definitions, as we know in any of our specialties, to be very clear about when we're talking in literature, because it becomes very confusing and fearful in a way.
Right.
And so how do we close that gap so that we're talking definitionally in the same way?
Yeah, no, it's a great question. The question is, we're talking usually in medicine about value leading with quality of life per cost, or at least talking, framing it as not cost or leading with cost, but talking about the quality of life and what you're getting first. Is that fair?
True, right, because you use the word value often, which is terrific in what you're using as cost divided by the quality, the definition.
Yeah,
we have the inverse, right? We say value equals quality over cost. And
so we certainly can flip the ratio and do that. And that may be, and not, to be, flip about it, so to speak. We can do that, and that may be a helpful way to do it. There is a metric or an approach of cost-benefit analysis, which is all about monetizing all the effects. They have started talking in the past few years about benefit-cost analysis. And there may be an important framing issue here that I take the point. I mean, in the field, and people have talked about this, that we need to lead with the quality or flip the ratio so that's quality of life over cost. So that may be helpful. Talking about cost is fearful. People don't want to confront costs first, and it makes it sound like it's all about saving money, and economists, who only care about bean counting and such. So I take that point.
yeah, and again, just to, because I'm not sure they're measuring the same things. When we say quality, it may not be that quality, and
Okay,
so
yeah.
is there an intersection between your cost effectiveness ratio and the quote value ratio we use? It's
Yeah, so this is an abbreviated version of a talk, There's a lot of discussion, attention to other metrics besides the QALY. We don't have to go to the QALY. There are many, many ways that we can and do measure benefits with quality of life scales, with all kinds of other instruments. The downside of many of those is they tend to be disease-specific or not easily comparable across diseases, or not reflecting preferences in ways that QALYs do. But yes, definitely there are other ways to measure, and that should probably be done alongside the cost per QALY. Yes.
Thank you for a very, very provocative discussion. One of the problems I have, maybe I missed this point.
Yep.
How do you define quality?
Yep.
And plug that into your formulas?
Yep.
And in these mega studies that are being done, do the investigators all agree on the definition of quality?
So it's a great question about how you define quality, and how do you define quality for the QALY. So, again, this is a large, growing, sometimes controversial field. We know a lot about how people respond to questions when you ask them about the quality of their life. There's a lot of data out there. We know it varies by who you ask. We know it varies depending on whether you ask patients or whether you ask people who are non-patients. Patients with a condition often will tell you they have a higher quality of life than non-patients think they have. For example, patients will often tell you they have a higher quality of life than physicians who are treating them think they have. Not always, but certainly for a lot of physical conditions, that seems to be the case. People adapt in ways not true for their mental health conditions. The reverse seems to happen. Anyway, the point is, there's no perfect way to do this. It will always be a field with some controversy, but again, the idea here is we want to try to put some numbers to it to better allocate our resources. And as I showed you these graphs, at the very least, we should be able to say things on this side of the scale seem to be much better investments in the sense that we'll get a lot more health per dollar if we do these things than if we do all of those things way out there. And some of them are way, way out there. We're treating, for example, and I didn't show you some of the extremes, but we're treating, as you know, many of you know, we're treating aggressively many cancers in late stages of life. Those are very hard decisions, very fraught decisions. But if you start to think about all the money that's going and all the benefits, the small benefits, it helps the conversation, difficult conversations. And I'm not the one to make the decisions, but we're trying to be the ones to help us have the conversations. So it's a long-winded response, maybe not a adequate one, but this is a hard field.
Question. Question.
Patient's perspective.
Yeah, there's a lot of data. We've done a lot of studies, others have too, yeah.
Question. Your talk was very logical, but it seems like frequently policy is not. And I was wondering if anybody has done a study to measure the frequency with which policy responds to an anecdote, like, Rory's
Yeah, right.
regulations around sepsis and all of that, versus a logical presentation of evidence.
I don't know offhand. Likely somebody has, because I think we know from our own experiences, anecdotes drive a lot of things, right? I mean, if a certain member of Congress has a family member, or if someone has a high-profile disease that gets in the news, those things drive policy. And we know, it's certainly today's climate, science is not to be, if we can editorialize for a minute, where it should be in informing policy. So I would have to look and see. I would like to do that study, but certainly there's a disconnect between the science and the emotion and the policy, and there always will be to some extent, but we seem to have gotten further and further away from the science and the logic and the ration. That's very unfortunate, I think. Yes.
Thank you. Two observations. The first, to paraphrase the movie, I'm shocked to find that there's a lack of logic in policy decisions. In terms of the second, a lot of the studies may have to go back and be done again. We're finding that the populations of patients that have been studied are far more heterogeneous than at first thought.
Yeah.
Studies not only in terms of typical types of receptors on leukocytes that will make certain subsets of a leukemia respond very well to a form of therapy with wonderful quality of life, and others won't respond very much at all, to even more mundane issues than antihypertensives found not to be all that effective until you do subset analysis and look at certain populations who had tremendous benefit. So one doesn't want to throw the baby out with the bathwater, and I think that as we learn more about personalized medicine, we're going to find a much higher quality for some of these expenditures, but for subpopulations of the original population studied.
I agree, great point. I showed you a few examples with screening based on risk factors, with the PrEP and we showed mammography. But that is true of all these studies, and undoubtedly in the future when we have more personalized medicine, better predictive modeling of who will respond and so forth, it will have enormous implications on the practice of medicine and on the cost effectiveness, because we will be able to do a better job at targeting resources to people who will more likely benefit. So yeah, I agree, and the more we learn, we'll have to go back and do the studies, absolutely.
Hi. Do you know of a study, or maybe you've written a paper, or do you know of a paper that's looked at the eligibility criteria for donated organs?
Yeah.
There's federal statutes, it's a private vendor. Mickey Mantle got a liver, Steve
Yeah.
Jobs got a liver
Yeah.
partly because he had his own private jet and could get to the
Right.
donated organ.
Yeah.
The balance
Organs,
between
yeah.
QALY and what other
Organs, yeah.
factors?
Sorry. Organs is a very interesting example from cost effectiveness standpoint. We often will teach cases. Imagine everybody in this room, I don't know how many people are here, 50, whatever, needs an organ, let's say a kidney, and we only have 10. Imagine and this is not that far off, right? We don't have enough organs for people. Now, how do we allocate the 10? One way to do it would be we could do it based on cost per QALYs. Imagine, hypothetically, we could figure out who is the best candidates, who has the best prognosis, and go around and say, the top 10 candidates will give us the most QALYs. You. And imagine we could do that because we have a lot of information. And a lot of you wouldn't get them because you're not good candidates. We're only giving it to the people who have the most life years and best quality of life. The other extreme is that's not fair, right? I mean, the other extreme might be, because that's not fair, we're going to put everybody's name in a lottery. 10 people get it who pull out the 10 pieces of paper that have the check on it. Now, in society, we tend to do a hybrid, right? We don't do the full cost per QALY. We don't do the full lottery, but we don't only do the lottery. Some people are just not good candidates, right? I mean, you may know a lot more about it, and it may differ depending on organs and lots of things, but it's a societal dilemma that we probably can inform with a cost effectiveness frame of thinking, but we don't want to only go that way. We want to override full efficiency, cost effectiveness, with a sense of fairness. In the ethical literature, we talk about fair chance versus best outcome. And, again, we might want a hybrid. So, but it's a tough problem when we have fewer organs than we have eligibles. So I don't know if that answers your question, but there may be other ways to think about it, but that's one way to, I guess, I would respond.
So it seems to me that the elephant in the room is rationing.
Yeah.
Which is really what you're talking about.
Yeah.
And the fear in America is that the insurance companies are in fact rationing or doing this quality assurance behind the scene. The only public insurance, the only insurance company I'm aware that did this publicly was the state of Oregon and their Medicaid rationing decision. But, with pre-authorization, it's pretty clear to some of us that they're using something to decide. I'm not sure it's cost effectiveness analysis because it never seems to make sense. But are you aware of insurance companies using your stuff yet behind the scenes?
So it's a great question. Oregon tried famously in the early 90s to do it, and the lesson from Oregon really was it's too hard to do. No other state copied them. Even they, in Oregon, really didn't do it in the end. They had a waiver which overrided cost effectiveness in a lot of ways. We do track insurers. They are very reluctant to publicly ration, not surprisingly. There's one plan in Seattle that uses our data to design a benefit package. And they use cost per QALY information to design, what they call the high efficient, and they use other information too. It's Premier Health Plan. That's the only one I know that does that. The other thing I think that goes on with a lot of private and even public health plans is this kind of information that I talked about indirectly has some impact. It impacts them when they negotiate drug prices. It impacts them when they put the benefit package together and the restrictions that go into the benefit package. So PCSK9s, studies showed was not cost effective at all. They didn't restrict it for everyone, but they restricted it to the very high-risk groups to get to the personalized medicine. People with hypocholesterolemia and family history. It's always hard to tie cost effectiveness directly to their policy decision, but that's kind of the way we seem to be able to do it in the US. Not directly rationing, but indirectly rationing. And that's maybe as best we can do right now until things get really bad, and maybe then we'll do more explicit rationing. So I'm happy to keep going, but if you want to, whatever you say.
I think it would help to be careful not to conflate two issues.
Yeah.
One is the measurement of cost and effect. The other is the decision about what to do with
Yeah,
that data.
I agree.
We tend to assume that if you measure things, that is the decision, and therefore you should or should not measure things,
Yeah.
or you should bias the measurement.
Yeah.
I think it would take the load off a lot of people and make the tasks clearer.
Yeah.
If you let measurement be done in a fair and accurate way and not assume what to do with it and then have another body and another method for deciding, therefore, what do we value? Because the decisions, whether they are meant, whether they are voiced in terms of money or value, are moral decisions. It is not a decision about how much money we have, but what we choose to spend that money on. And that decision is made in quite a different way than measuring how much money we have and how much that treatment costs.
Listen, I agree with you fully. We're in violent agreement. I mean, we're the analysts providing information, hopefully doing it well and objectively. But the decision makers have to take it and morally, ethically, financially, bring all the information to bear and make decisions. So I agree with you fully. We need to separate them. And I did say, it's not to say we shouldn't reimburse these things out here, but this is information for the decision makers to make. So I agree. Those are good points.
Hi, so I'm a medical student, and I'm also pursuing an MBA at the same time. So I've consciously decided to think about both the intersection of healthcare and the costs associated with it. However, so far, in my medical education, cost effectiveness of certain therapies that we're taught about isn't something that we discuss during our lecture or our small groups or anything like that. So could you talk a little bit more about maybe what the role of medical education should be in this? Because I think that this is an important topic that students should be thinking about from day one. I mean, we talk about things like monoclonal antibody therapies, which are super great and really, really effective, but very expensive. And I don't know how much of my class is aware of that and isn't aware of that.
No, it's a great question. So a couple of things. It would be great if medical students were exposed. I mean, you have a lot to do, I understand, as medical students, but could you add this to the curriculum somehow? Possibly. There's a very, very, very good medical health policy department, steps from where we're sitting right now with great health economists who I know interact with medical students sometimes, and maybe there's opportunities for you to do that. Undoubtedly in your careers, you're going to come up against very pricey new drugs and medicine, and there will be struggles about how to think about it. And so I would encourage you to take health economics class if you can. You maybe get some of that in your MBA program. There's a lot of good literature. The New England Journal publishes perspectives on this all the time, and this is getting into the medical literature, the mainstream medical literature. So, by all means, I think you'll get exposed to it, and definitely will encounter it in your careers. We will have the $1 million gene therapy coming soon, and on and on and on. So, stay tuned. So I want to thank my friend Harry for helping me put the slides together before I forget. So.
Thanks, Dr. Neumann, for presenting the foundational elements of not an easy issue, as you saw from the questions and the discussions, on how to distribute, share, and other aspects of healthcare. It's not simply one-on-one, so it's complicated. So thank you very much for that. And I know there are many more questions, and I think we could be here for another hour or probably more. Yeah. And I had warned Dr. Neumann of that. But the clock ticks on. I can't control that. So I think, thank you all very much. And join me in thanking Dr. Neumann.
Thank you very much. Thank you.
And there is a reception on the 5th floor of the County Library. For those of you that have the time to come on down there, there'll be a chance to meet the people as well as Dr. Neumann. Thank you all very much.
Thanks.
Is there anything else to turn off here, or they'll turn off?